The fourth group, the children who molest, sorry, that was my third group. What did I skip? Oh, the sexually reactive. I forgot. I'm sorry, I skipped over the second group. The sexually reactive kids, they also display more sexual behavior than the children who play. They often do feel shame, guilt, and anxiety about their behavior. They usually show more behaviors such as excessive public masturbation and all kinds of overt sexual behaviors, like insertion of objects into their own vaginal organs or vaginal parts or other people's vaginal parts, but they are also, relatively speaking, amenable to change. When caught, they are very ashamed, but they acknowledge that the behavior is something that needs to change, and they're much more open to receiving help in doing so. Even though they feel helpless changing it themselves, they are open to receiving help much more than the next two groups. Yes? In group 2, by its name, this is why she called them reactive, you find a lot of highly sexualized exposure, whether sexual abuse or exposure to a lot of sexual behavior by adults in their environment, or total lack of boundaries on sexual exposure via media, internet, and so forth in their environments. This is why she called them reactive, because they are reacting to highly sexualized environments. That's what you find in their surrounding. The third one, just to recapture, are those who engage in extensive, much more extensive, but still mutual sexual behavior. And the fourth one, the children who molest, go way beyond the what we would consider developmentally appropriate childhood exploration or play. Like the third group, they are very focused on sexual content, on sexual behavior, on sexual talk. But their behavior differs from the previous groups by the fact that it includes a truly almost full repertory of serious adult sexual behavior. Yeah? Yes. Very flat affected. They're not excited, they're not angry, this is just what they do. Yeah? That's how they relate to their peers. Yeah? Absolutely not. Absolutely not. I should say, if that's the question, I should say that the first group is where we would like most of our children to be, obviously. The second group is an unfortunate reactive behavior to very bad things that happen. The third and the fourth are the more problematic groups that we don't fully understand and that definitely are at much higher risk for later reoffending, for the behavior becoming entrenched, and for the need of appropriate focused treatment for it to stop. Well, no, actually, one of the things that differs here is, like I said, yes, there is a group of children who are reactive, and we can see it rather simply. However, if you recall, I said before, there are no real profiles that characterize all children with sexual behavior problems. Unfortunately, there are those that are not so simply, pegged into, oh, this is why it happened. While we would maybe like to think so, it's not always the case. So, yeah, why don't I take one more question, then go on, and I assure you that this time I will make a huge effort to leave a lot of time for discussion. Okay? This is the chart for the females. You want me to go first to the males? Okay. Okay. One point that I would like to make, which is also of interest, is that actually sexual behaviors that are problematic in children are seen by both, in both boys and girls, whereas in adolescent offenders tend to be much more males than females. That's an interesting tidbit to just throw in there. But let's go to the male chart first. Here. So, I'll just go down it. I'm sorry that it's small. Dresses like the opposite sex. About 13.8, 14% of 2 to 5-year-olds, and then it goes down by a lot. It stands too close. About 30% of children boys up to age 5, 15% of 6 to 9-year-olds, and then it goes down. I'm just going to go over the big numbers, okay? Maybe you can hear me even if I'm not there. Okay, let's see the highest numbers. Masturbates with the hand, about 17% of children, boys age 2 to 5, about 13% of 6 to 9-year-olds, and then it goes down. Touches breasts. Obviously, these are boys. We're talking about touching the breast of somebody else. Touching the breast of somebody else, about 42% of boys up to age 5, 15% almost of the 6 to 9-year-olds, and then it goes down. Touches sex parts at home. Yes, so here is the mother who caught her son masturbating. Okay, he was an adolescent. These charts are not about the adolescent, but look at the touches sex parts at home, exploring one's own body and one's own bodily sensations. 60% of boys 2 to 5 years old, 40% of boys 6 to 9 years old, and then it goes down slightly, goes down a lot, sorry, in the pre-pubertal years, and goes up again, of course, with adolescence and the onset of adolescent sexual changes and hormonal changes. Tries to look at people when they are nude. Gee, wow, that's a very, that's curiosity. That's 27% of boys 2 to 5, 20% of the 6 to 9. What else have we got here? Gets upset when adults kiss. I'm not sure that that is only in the context of sexual behaviors. It's also in the context of other things, but nonetheless, 13% and 6.5%. And what do we have here? Hugs adults not known well, 15%, and 17% very interested in the opposite sex, goes down to about 14% between age 6 and 9. Well, of course, reflecting the natural processes of our development. Now, if you want, you can look at the female age group. Again, look at the big numbers. Stands too close, about 26% of the 2 to 5-year-old, 18, 19% of the 6 to 9-year-old, touches sex parts in public. 15% of the little girls, 6.5% of the older ones, masturbates with the hand, 16% of the little girls, then it goes down. See, sexual pressures are absolutely effective. Social sexual pressures. 43.7% touches breasts, 16% of the older girls. 44% touches sex parts at home. 44% of girls aged 2 to 5 at home. 21% of the 6 to 9-year-olds. 29% tries to look at people when they are nude, when they're 2 to 5. 21% when they're a little bit older. Shows sex parts to adults, about 14% of the little girls. Gets upset when adults kiss, 12%. What have we got here? Hugs adults not well known, 13%. And lastly, very interested in the opposite sex, 15%, 14%, 29% by the time they're 10 to 12. Okay, there are no real figures about the prevalence or incidence of sexual behavior problems in children, really, in the general population. That's a very inherent problem to the topic that we're looking at. We do see, as I said before, an increase in referral of children to various, child protective services, treatment facilities, and so on for sexual behavioral problems. And it's not clear, like I said, whether the incidence of the behavior increased because of our much more sexualized society, because children from age, I don't know what. In many families, children watch TV as an ongoing participant in the family life. The TV is on. And whether what's on is Friends, which is relatively mild, but includes stuff that children didn't used to be exposed to 30 years ago, or whether it's stuff that's much more blatantly sexual than that, we don't know. It could have definitely led to an increase in the sexualization of children, or a changing in our definition of what is problematic, or a change in our policies, personal and social, about reporting. Because, maybe the same thing had been happening all along, but it was not considered okay to report it. So we don't know which of that. I wanted to tell you that it would be important, when you keep in mind prevalence and incidence of these phenomena, to take a moment to think about something not necessarily so pleasant. I'm not going to ask you. I'm just asking you to think about it for a minute. Let us each think for a moment about our own childhood and growing up years. And let us think if today, with our adults' eyes, we think that we were in some way approached by somebody sexually inappropriately. Think about it for a minute. Whether it led to actual sexual violation or boundary crossing of any kind, and whether it was stopped somehow. But do you think that you could have been or were approached in such a way that could have been a problem throughout your years growing up? So I can tell you that in a study that asked mental health professionals about their own experiences before 13 years of age, 73% recalled having engaged in sexual behaviors with other children. 34 recalled showing their genitals to another child. 16% recalled simulating intercourse with another child. And 5% recalled inserting an object in the vagina or rectum of another child. That is, of course, just normalizing data about sexual behaviors between children. What I asked you before was actually to think about whether you think that someone approached you, an adult or another child, in a way that would have been problematic. And the numbers about that, when you ask, I don't have it in front of me, are very high. Very, very high. There's almost, in my experience, in my clinical experience, and since I'm interested in trauma and in these things, I tend to ask my close friends somewhat personal questions sometimes, if they're open to it. In my personal clinical experience, there's almost no adult that has not a single experience of this nature. I actually have a table that is somewhere in there, I'm sure I'll stumble upon it, of some figures from a hotline in England where children call about different problems, and that table summarizes the information about children calls where the main problem was sexual behavior, sexual problem, and the numbers the percent according to the assumed age of the person who was doing it with them. The numbers are, interesting to look at. the last decade of research, which is really where the most bulk of the studies about children's sexual behavior comes from, suggests that there are several forces that do maintain, either create or maintain children's sexual behaviors, and those include familial, social, economic, and developmental facets. Continuing factors that maintain the behavior are definitely sexual abuse, as we said, but also, most importantly, to remember for us, it seems that sexual boundary crossing in children is very often actually associated, perhaps even more frequently than with sexual abuse of the child, with physical abuse of the child and severe neglect in the home. And of course, like I said before, exposure to sexually explicit media, living in a highly sexualized environment, and exposure to family violence. We talked a little bit about typology. I think that the main point to remember is that even though various researchers tried to clump subtypes of sexual behavior problems in children, there is a great deal of overlap between the groups. So while it is important to remember some of the factors that we talked about, some of the points that we want to think about when we assess and evaluate the child, like the developmental and age, all those things that we talked about when I reviewed the differences between the four groups, according to Johnson, for example, and other people. There are many attempts to make these, clusters, but there's a great deal of overlap between them. So these are just points for us to think about, but they're not really distinct groups. As to the qualifications of the assessors of sexual abuse, I think that I would like to say a couple of words about that. We tend to shy away from things that we haven't done too much. And as a result, we may not see what we don't feel comfortable dealing with. And I think that would be a very bad thing for us to do, given that sexual behavior problems among children are really very not good to use two negatives, right? They are not uncommon, or in other words, they're fairly common. We see them a lot if we have the eyes to see them. The children come with these problems, especially children who come to our attention anyway because of some other behavioral problems. In many, many children, sexual behavioral problems are only one facet of a wider array of behavioral problems. So we need to be able to see it. And for that, we need to make sure, if we work in a setting that brings us in contact with such children, we need to somehow make sure that we are familiar with some data, some facts about child development and child sexuality, such as these things, so that we have something to compare what we see with, and that we have some kind of an understanding, that we gain some understanding of the child's environmental, family conditions, the nature of parenting that they're getting, what kind of supervision is there around. Because, in families where two parents work and the child is left alone a lot with other children, it has been actually shown empirically by a study that I don't remember, but it's also something we all know as parents. When children are left unsupervised to themselves too long, they will get into trouble. That's a natural fact of life. What kind of trouble? It really is a very open-ended thing. They will do all kinds of things we don't want them to do. They're not so good at deciding, now I'll play this game, and now I'll play this game, and now I won't do this, even though I had this clever idea that I could. Rather, I will use an alternative behavior like my mother would like me to. They are not so good at doing that. So if you leave them by themselves unsupervised, they will get into trouble, and part of the trouble will be sexual exploration as part of what may start, like I said, as natural play, but can go into different directions depending on the personalities, depending on a lot of things involved. So we have to understand those circumstances in order to know, are we looking at an environment where the child got into this behavior primarily because of lack of supervision, but really is not an entrenched behavior. And we have to also look at cultural variations in the norms and the attitudes and beliefs about child rearing and child sexual behaviors. Perhaps I will say here something that I thought I would say later. I will read to you a little description of something that was written by a very famous American researcher of childhood sexuality. His name was Floyd Martinson. He lived until 2000. And what he wrote, that I'm going to quote you from, was written in 1994. So this is not, ancient scrolls. This is like fairly recent, about American families and American culture. And he said, according to one researcher, in American society, mothers are assured that the interaction with a baby that is intimate and sensual is appropriate. There is no quarrel with the fact that this is needed and okay, he goes on to say. But he says, in childhood, it stops. And children are discouraged in American society from close physical contact with their parents. According to one researcher, the American child-rearing climate is one of weaning before age 2, consistent positive reinforcement of self-reliance and achievement, the encouragement of male physical aggression, lower status for the female child, the use of supernatural forces to elicit moral behavior, and culturally sanctioned physical violence in disciplining children. And he goes on to say, in a study of intimacy of 4-year-olds, Blackman in 1980, that is also not from the Dead Sea Scrolls, has shown that at least by that age, already at least by 4, not before, but by 4 for sure, permission to touch parents has been proscribed. There was not much touch between child-parent, and what there was not interactive, was more child-initiated and not interactive. The blocked response was the essence of their emotional experience. That was the impression of a child sexual researcher in 1994 about American culture. I think that that stands in stark contradiction to what the norm is today, with many other models such as Sears attachment parenting and all kinds of other models that encourage much more, much warmer parent and child relationship and much more physical parent-child relationship into older ages. And certainly it's in stark contrast to families where there is on one hand very little affectionate, warm connection, physical connection between child and parent, but a lot of harsh, physical, violent connection between adults and children. So assessing the ecology of the child, the ecology of the family is key in assessing childhood behavior problems, including sexual behavioral problems. But it's important not to focus on the sexual behavior problems more than on other things, and at the same time it's important to see them and not look away from them. Okay, I think we can go on from here. As to the question that was asked before, I would like to say that interventions with children, more than even with adolescents, but still with adolescents too, certainly with children, the interventions that have been seen to be most effective involve the parents. We can't really intervene with the child alone. Any type of behavioral intervention with young children requires intervening with the parents, because either as we said, ecologically seen, either the child is reacting to its environment and to things that are happening in the environment, and then we need to help the parents change the environment in ways that will make it safer, that will make the child less exposed to sexualized material and behaviors, that will help the parents set better limits on viewing TV, internet time, all kinds of things like that. And of course, if there is abuse, we have to intervene with that, if there are possibilities that things are happening in the environment. But even if there is no abuse, and even if the environment is not seen as something that needs to be directly changed in order to reduce sexual behavior problems in the child, we need the parents or the caregivers to reinforce and maintain the changes in the behavior of the child that we want to create. Yes, they need to be the ones on an ongoing basis reinforcing what we want, and we definitely know that reinforcing in every level of behavioral intervention, even with rats, I can tell you from personal experience, is very effective. It's much more effective than punishment, because punishment often leads to freezing fear that constrains the rat or the child. Forgive me for the comparison. I certainly don't feel this way about my children or anybody's children, but there are certain principles of behavioral change that we apply throughout the chain of living mammals, and they work. That's the good news. It works. I can tell you that many, many years ago at the laboratory of Professor Schuster in Haifa, I saw with my own eyes how I could train rats to behave very cooperatively in very intelligent ways, relatively speaking, by using simple reinforcement methods. We certainly can take some encouragement from that, knowing that these methods do work with children as well. But we need a good, consistent adult caregiver that will reinforce whatever changes we want to introduce. I wondered if we should speak a little bit about how behavioral change programs are done. I mean, I wanted to say that in interviewing the children about their sexual behaviors, because this is our focus right now, when we want to change a behavior, we have to understand exactly, this is the key, if you like, the one-line description of behavioral change programs is we need to understand what the behavior is, the specific behavior that we want to change. We can't decide to make the child a better child or make them behave more politely. We have to break it down to very specific and concrete goals, such as I want the child to say hello when he meets a person and goodbye when he parts from a person. That's a very concrete operational definition of one aspect of politeness. Yeah? And if I want to increase that, I have to see what are the conditions under which this child greet or doesn't greet people when he meets them. What does it look like? What happens? How can I increase this behavior by making sure that the consequence of the child doing so will be meaningful enough for the child, positive enough for the child, that he will want to do so. The same principle works for behavioral change with regards to sexual behaviors. I will say one thing. We do have a particular problem with some of the behaviors that occur in privacy and are autonomically, inherently gratifying, such as for some children, excessive masturbation. Unlike the behaviors that we can offer alternatives for, this behavior is more problematic because there is no exact alternative for the gratification gained by masturbation. Have you thought about it? It's a problem. Yeah, not bad. Not bad, except still, I think it's a debatable question. I think it's not a bad analogy. It's not a bad comparison. But I think that we still believe that eating has a more social context often than masturbation, and that the neural pathways involved and the gratification involved is somewhat different. I think it's though not a bad comparison, and one could. Right. So I think that's a very important point, that one has to look at what are, and again that falls right back into the basic model of behavioral change. We have to look at when does the child do it, what leads to the child doing it. Does he do it because he got anxious? Does he do it because he's bored? Does he do it when he's alone behind a closed door, and therefore we have to take the door down for a while so that we can supervise it better? What are the antecedent conditions, and how can we intervene and create a distraction, an alternative behavior that will be good enough, although indeed we can't get quite the same gratification. But if the gratification is not just merely the physiological dopamine high that we get when we orgasm, if the gratification can be reduction of anxiety, if the gratification can be that he's not bored because he's doing something else, if the gratification can be something interpersonal because the child was lonely and is seeking that, if the gratification can be excitation because the child is under-stimulated, those things we can find alternative behaviors for, yeah? Right. And that, I think, goes very much back to a point that's, again, something that my colleague here mentioned before, the pressing on the spring so hard that it wants to jump in the other direction, which in my terms would speak to the aspect, very, very important and critical aspect of parent-child relationship that has to do really with the mutual regulation of affect. It's such an important aspect of our relationship with infants, children, and adolescents. We have to help them figure out how to not only regulate their behavior vis-a-vis other people, what is appropriate, what is not, and so forth, but perhaps one of the most important aspects is the capacity to internally regulate their own excitation, feelings, needs, frustrations, aggression, and so forth, yeah? And what you're talking about is one of the ways in which we can help children, and sometimes for that we have to first help their parents, learn self-modulation skills. That's part of what we would like to teach parents. And I think there is a whole array of parenting skills which we have to often teach the parents of our children, the children who come to us with the behavioral problem or with the sexual behavior problem. In order to be able to implement change, parents sometimes have to learn very basic parenting skills that involved modulation and how to respond appropriately, how to say no. This morning at the hotel that Arlene so kindly put me in, there was a father, a very young man, with 2 little children. And we were eating at the dining room together, just him and his children and me, and I could hear him interacting with them. And I thought it was so beautiful, the way he said no. We have to know how to say no. It's a very important thing, and many people don't know how to say no. They say it either too violently and too harshly, or they don't say it at all. And this man said, "No, David. No, David." He didn't ask his son. He didn't apologize for it. He said it firmly and kindly. Couldn't be better. I wish I could videotape him. He said, "No, David." And he continued to hand him something and to give him, and he went on with what he was doing. It wasn't like, no, David, and stop and sort of highlight it, you are bad right now. It was just, no, we don't do that. And here is what you wanted, and here is what you wanted, and it was beautiful. We don't necessarily all know how to do that. We don't all know how to redirect a child's attention. We don't all know how to play. I have a patient, and I'm not talking about your slum, neglected, third-generation parental neglect person. I'm talking about a highly educated person from a very highly achieving family who didn't know how to be with her children in any other way other than the overburdened, harassed mode of, okay, now we have to do this, and now I have to take you here, and now I have to take you. She didn't know how to sit down and relax and try to find somewhere within her repertory something that she can actually do and enjoy doing with her children. Play in an enjoyable way. She did know that sometimes she needs to take them to the park, but that was very unenjoyable for her. And you know what? That comes across too. So often we need to teach our parents first some basic parenting skills that have to do with limit setting, that have to do with redirecting, that have to do with finding enjoyable ways that reinforce and strengthen the positive, affectionate, warm relationship with the parent, so that the parent's positive comments and positive regard will become potential good and powerful consequences for the behavior that we want to encourage. I think I have only, we want to stop at 12:30, so let me stress again the point of the temporal limitation of any assessment with children, and make sure that we know that we need to do that for very short periods of time and reassess. I also wanted to stress again the point that while we don't all feel that we are specialized sexual abuse and sexual behavioral problems experts, we all need to become comfortable enough with looking at it as simply another subset of behavioral change which we can master and for which we can access very specific behavioral change approaches that were proven to be very effective by research. They exist on many, many sites on the computer, on the internet, and I'll be very glad to share them with you. In fact, I will talk with Arlene, perhaps in the next workshop, which we do about working with parents, perhaps we can actually go more systematically and closely through one of these approaches. I do want to say I will not go over treatment outcome with you, but I will say that treatment has been shown to be rather effective in relation to sexual behavioral problems in children and even in adolescents. What we see, which is even more important, is that it has been, when followed, when the empirically tested and proven protocols have been followed, it has been most effective with those children and adolescents that are the highest risk offenders, namely those who offended in the most severe way, actually responded better to the treatment. And that is a very encouraging statement, because we would like, of course, to make our communities safer, and we would like to believe that there is something we can do about it. If I may, I would... It's not clear. It's not clear. It's actually, I was going to say, when I was going over the study more in detail, I was going to say, it's interesting, there is no explanation for it. Why the high intensity, you know, there is a model that is very clever, which I can also share with you, which is called the risk, need, responsivity model for intervening with sexual behavioral problems in children, which means essentially you have to match the level of intervention, the intensity of intervention, to the level of risk that this individual shows. Level of risk is based on what they've done and on a very particular assessment of what these people, what's their name? Bonita and I forgot the other person's name, very famous for this model, what they call criminogenic factors. They specify 7 criminogenic factors, which are things that are in the environment of the individual, in the history of the individual, that include negative peer influences, the type of family environment, all kinds of things that have been shown to be associated with maintaining these behaviors. And they have been shown as maintaining sexual behavior problems not by some theoretical or even clinical judgment, but simply by examining actuarial data. How did it, just like insurance companies do, what is related to a higher life expectancy, this and this and this and that, based on actual correlational studies. The same was done and rendered 7 criminogenic factors, and they say if a person is assessed according to that at high risk for reoffending, they need to get a much higher level of treatment, and if a low-risk person gets it, they actually got worse. So it's very interesting what happens there, and it's not totally understood. And another thing that's not totally understood, by the way, is the effect, the lower effectiveness of treatments that are inpatient as opposed to treatments in the community. It's interesting. My experience was primarily on an inpatient unit. And I thought, gee, wow, this is good. Let me tell you, when I was on an inpatient unit with the adolescents, I was almost like a, representative of God. I could decide exactly what they could do. They didn't do the right thing, they lost points. They lost points, they went to level 1. Level 1, they couldn't go down with the other kids to the yard to smoke a cigarette in the break. They couldn't participate in certain activities. If they were good, they gained points. They went to level 2. Level 2, they could do this, they could do this, they could do that. And since I had full control over their environment, it was fairly easy, and I thought that it was good. Let me tell you something. Once I went to private practice, and I lost that control, I mourned it, because I thought, gee, what do I do now? What do I do now with an adolescent who comes to my office, is belligerent, horrifically misbehaved with her mother? I'm telling her mother that she needs to set limits and this and that, and at the end of the session, the adolescent storms out. The mother says to me, thank you, Dr. Felsen, and hands the car keys to the child. And I'm like, oh, I should have this child on an inpatient, that would, be easier. But research doesn't support that. Research, to the extent that we have, and we don't have enough, about the outcome of treatments of residential facilities and inpatient facilities for sexual offenders who are children and adolescents. But to the extent that we have it, we see that it's less effective than treatment in the community. Why? I can only say one thing about that. Maybe because it's much more naturalistic, and there is a much better, from the very beginning, a much better relationship to the real life of the child, and it happens under, the generalizability of the treatment is inherently there. Why the high-risk offenders respond better than the low-risk offenders baffles me. Last thing that I wanted to say, we can say a lot more, and I apologize for many of the things that I omitted, but I'm sure that Dr. Pelkovich will speak to them very eloquently after me, so I don't worry about you not getting it. But I will say one thing. Back to the implicit attitudes that we have as people and as parents and as therapists. I cannot stress enough how important that is. I think that it's, there's a couple of a therapist and her husband who do a lot of workshops for couples, actually, not for parents. Their name is Hedi and Yumi Schleifer. They're a couple of older, observant Jewish people. She's a psychologist and he's not, but he works with her together. And they have this beautiful sentence: the past is never the past. The past is with you in every step you take. I very much believe in that. Our past is with us in every step we take. And the only way to expand and improve upon what we don't necessarily want to carry on from our past is self-reflection. So, for example, even small things that have to do with our normative way of imparting our attitudes towards sexual behaviors in children, such as not naming sexual parts, not naming sexual behaviors, or even sometimes you see parents mislabeling sexual behavior. So the child does behavior number 4, the child touches sexual parts in public or in front of the parent, and the parent said, if you need to go to the bathroom, you can go to the bathroom, don't touch. The child doesn't need to go to the bathroom. The child is touching sexual organs for a sexual feeling or whatever sexual thing is happening at that moment. He's not or she's not needing to go to the bathroom. Mislabeling or not labeling sexual parts, behaviors, feelings, issues leads to a very vague, unclear, confusing idea of sexuality for children. Some people find their ways better with it, as many of us did, and some people less well. What certainly happens is that if we don't work on our own discomfort with it, we restrict ourselves in our capacity to respond appropriately, even to the natural teaching moments that occur with our own children. And I'll share with you one moment like that before I have to stop. My daughter was 3 years old. I know that because I remember I was pregnant with the second one, when we were in a small zoo in Israel, somewhere in the north. And we were looking at the different animals, and then we came to the place where it was open, and there were a lot of very big turtles of some kind. Not the usual Israeli turtles, turtles like that. And a lot of them, maybe 20. And I'm standing here with my 3-year-old, and a guy is standing here with his little boy. We just came there, and we're looking, and lo and behold, I do not know what was the occasion, but all the turtles were doing reproductive behavior. All of the turtles were two in a very strange way, and my daughter said she was scared. She thought that they were doing something bad to one another, and she anyway didn't understand it. And both of them, the 2 children at the same time, mine and his, we weren't connected. We just happened to be there. Go, oh, what are the turtles doing? The other guy goes like, let's go see the Bambis over there. Which is, one way of dealing with it. And you can think for yourselves, what kind of a message does that give to the child? I have to say, I took a deep breath, and I said to my daughter, who was about 3, I think what was pretty age appropriate, I said, the turtles are engaged in a big hug of love, which is how little turtles will come to the world. And we built upon that in later occasions. What I'm trying to say is we have to use reflection to expand our own internal stance with regards to those things which are the least comfortable for us, in order to allow the past not to control us in those ways in which we don't want it to control us, and in which we want to improve upon it for our children and for our patients. I would strongly recommend one question to ask ourselves as an exercise, which is, again, in the words used by Hedi and Yumi Schleifer, think of the least comfortable sexual neighborhood in your own internal landscape and just go there, take a walk there, see what it was like, see what you learned from it about your own sexuality. What truths about sexuality did you get from it? Are you aware that those are the truths that you're walking around with? Or do you want to change them now that you're actually looking at them as an adult? Just bring the unthought known, as Bolas said it, to the foreground so that it can become known by you and you can choose and you can act better in your own life, in your own sexual, intimate relationships with your own children and with your patients. Thank you very much. Right, not so much, but I think by about third less good than the programs, outpatient programs. What I do want to show you, just one second if you don't mind. This is just to end on an optimistic note. This is a table that I took from the clinical report of the American Pediatric Association. No, sorry, from the article about the risk-need responsiveness model. And it shows the success rate of this treatment, risk-need responsiveness treatment with offenders. The recidivism, 0.29 doesn't sound so hot, doesn't it? But you know what? Look, bypass surgery, only 15. Not so bad. Oh, yes.
Freud dealt with adult sexuality. The one who actually dealt with childhood sexuality wrote the text in, I think, the late 1950s, early 60s, and she died recently, was Dr. Eleanor Galen.
Right, but Freud, about 100 years ago exactly, wrote the main work on sexuality, which was the three essays on sexuality, which is where, for the first time, we spoke of children having sexual feelings ever in our documented intellectual discourse. Absolutely, absolutely. I think that one of the reasons, while I do think that Freud was a genius who said a lot of things that afterwards were said by other people as well, I think the main point there was simply the cultural, social revolution that was created with those two discoveries he made. Any other question? Any other comment? One more thing, back to your question, which obviously stuck with me, about what do we do with the child. I think, like I said, with children, in any type of intervention that has to do with behavioral change, we make very simple, concrete rules. We do not, even though we're talking here about behavioral cognitive models, with young children, obviously their cognitive abilities are limited. They're not going to understand, and they don't need to understand the cognitions behind it still, much less than the adolescents. With children, we really much more focus on the behavioral thing. We state, we don't do that. We create the reinforcing consequences for it. They don't need to understand why it is. They just need to be consistently reinforced. And in that way, again, pardon me, just like the rats, the behavior that you want increases and the behavior that you don't want doesn't increase. And if it doesn't work this way, it's a very good indication that you have to reassess what your analysis of the behavior was. Did you really address the behavior that you want, or are you addressing something else? Did you discover what the conditions that make it happen are, or did you not? Did you miss it? Did you discover what really reinforces this child or not? Change it. Do you have adults or caretakers that are consistently helping you change it, or are they inconsistent? Or maybe the parents are consistent, but somebody else in the ecological environment of the child, who's very important, is doing either something opposite or not supporting it. That's what we do.